Good day, I am Dr. K Gireesh, neurophysician and neurosurgeon. This is the RNA series 65. The RNA series means random questions in neurology and neurosurgery with answers by Dr. K Gireesh, that's myself. This is to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. The question that I am addressing in this series is, what is the revised diagnostic criteria for neurocysticercosis? Well, neurocysticercosis is a parasitic infection of the central nervous system, and this is actually as a result of consuming the larval stage of the Taenia solium or the pork tapeworm. The revised diagnostic criteria for neurocysticercosis and the most widely used is the 2017 revised Del Brutto criteria. These criteria emphasize that neuroimaging is central to the diagnosis, while serology and epidemiological factors provide only supportive evidence. They include the three criteria: absolute criteria, neuroimaging criteria, and the clinical exposure criteria. That is, absolute criteria, neuroimaging criteria number 2, which can be divided into major, confirmative and minor, and clinical exposure criteria. Clinical bar exposure criteria. The absolute criteria, let us see that. It is the presence of any one of the following establishing a definitive diagnosis. That is, histological demonstration of the parasite from the biopsy of a brain or the spinal cord lesion, direct visualization of a subretinal cysticercus, demonstration of a scolex within a cystic lesion on CT or MRI, hole with dot sign. So that is the absolute criteria. The neuroimaging criteria, which can either be major, confirmative, minor. Three things are there, subdivisions. The major neuroimaging criteria include: these are lesions highly suggestive of neurocysticercosis, cystic lesions without visible scolex, enhancing lesions, ring or the nodular enhancement, multilobulated subarachnoid racemosis, typical parenchymal calcifications suggestive of neurocysticercosis or NCC. We saw the major inside the neuroimaging criteria, the major features we saw. The other is a confirmative. These strengthen the diagnosis by showing characteristic evolution, resolution of the cystic lesions after cysticidal therapy, spontaneous resolution of a single enhancing lesion, migrating ventricular cysts documented on sequential imaging. Then, so we saw the major, the confirmative. Now the minor under the neuroimaging criteria include supportive but not specific hydrocephalus, abnormal leptomeningeal enhancement. So we saw the absolute criteria, we saw the neuroimaging criteria, which is major, confirmative and minor. Now the third component is the clinical bar exposure criteria. Now these provided indirect evidence like positive immunologic tests, anti-cysticercal antibodies, circulating cysticercal antigen assays, systemic cysticercosis elsewhere in the body, household contact bar carrier of the Taenia solium, clinical manifestation suggestive of NCC, that is neurocysticercosis, like seizures, headache, raised ICP, focal deficits, or residence or travel in endemic region. So we saw the absolute criteria, the neuroimaging criteria may be major, the confirmative and minor, and the clinical exposure criteria. Now, there is a definitive based on these three criteria, you can make a definitive diagnosis provided certain things are there, probable diagnosis provided there are certain criteria there. In a definitive neurocysticercosis, when do you say that? The diagnosis is definitive if any one absolute criterion or two major neuroimaging criteria plus at least one exposure criterion, or one major plus one confirmative neuroimaging criterion plus exposure criterion. So that is the definitive neurocysticercosis. Absolute criteria, that is neuroimaging criteria, major, confirmative, minor, and clinical exposure criteria. Now additionally, patients with one major plus one minor neuroimaging criterion plus exposure may be considered definitive after excluding others like tuberculoma, metastasis, abscess, toxoplasmosis. Now I told you about definitive, now probable neurocysticercosis. One probable, when you call it as probable neurocysticercosis, one neuroimaging criterion plus a strong exposure without fulfilling the definitive criteria. This is a probable neurocysticercosis. Now, the 2017 revision simplified the diagnosis and made neuroimaging mandatory, reducing the over-reliance on serology and epidemiology alone. Neuroimaging became the cornerstone of diagnosis. The important reference for this is by Del Brutto, revised diagnostic criteria for neurocysticercosis in the Journal of Neurological Science published in 2017, page 371 to page 202 to 210, and 371. Now, who is Del Brutto? Oscar H. Del Brutto is a Ecuadorian neurologist, neuroepidemiologist, and a researcher internationally known for his work on neurocysticercosis, stroke, epilepsy, and tropical neurology. He has been one of the leading authorities studying infections of the nervous system caused by the Taenia solium, a pork tapeworm. His contribution to neurocysticercosis, Dr. Del Brutto and colleagues developed the original diagnostic criteria in 2001, published with collaborators including Vedantam Rajashekar and others to standardize the diagnosis using clinical, imaging, immunological and epidemiological evidence. Then came the revised diagnostic criteria in 2017. Dr. Del Brutto led the revision along with experts such as Thomas E. Nash, Clinton, White Jr. and Vedantam Rajashekar. The revised criteria emphasized mandatory neuroimaging and refined the diagnostic categories to improve accuracy. Now, why Del Brutto is important? His criteria became the international reference standard for diagnosing neurocysticercosis and are widely used in neurology, neurosurgery, infectious disease, tropical medicine, clinical research and epidemiology. The key publication is Del Brutto et al., as I have told you earlier, revised diagnostic criteria for neurocysticercosis, the Journal of Neurological Science 2017. That's indeed the features of all the criteria for diagnosing neurocysticercosis. I have told you absolute, the clinical, as well as the third component of the diagnosis. Thank you very much.